One of the things that I've noticed about working in information governance for the time that I've been working in it, which is far too long, is that people tend to react in fear to the term information governance, and they also tend to stop listening or worry that it's too complex or that it's too difficult and that it's something that is done in a magic box far over the horizon by people probably using some kind of arcane methodology. It isn't. I would tend to refer to it, rather than information governance, as enabling information sharing. You all have obligations to share information, you have reasons to share information, and that you're all trying to do it for the benefit of patients, whether that be the direct benefit of direct care or the benefit of trying to provide a planning for your system or commissioning going forward. And what information governance is the kind of the rules of that particular game. And it's how you get from A to B. And that's what information governance does for you. In the current context, some things coming over the horizon that are worth bearing in mind. We've got the new European regulations, so we've got the interesting relationship of Brexit and everything that happens. We're still going to have to take account of what are called the general data protection regulations. The other thing that is expected in short order is the government's response to the National Data Guardian's review of consent and opt-out and cyber security. So this was Dame Fiona Caldicott looking at what exactly the expectations are around a patient for how their data would be used to provide care. Now, in terms of the way that you're working and the things you're trying to do, and listening into some of the sessions that have gone on today and hearing some of the topics, you're looking at new ways of working and new ways of partnering and new ways of working with social care and getting new kind of members of staff employed, using hubs, using federations, working more closely with 111, walk-in centres, all these kind of things. And all of these have a kind of a set of IG challenges about getting not only the patient through this pathway, but also the information to make sure that patient is cared for. The best kind of way of starting this is that kind of the fundamental understanding that in order for you to use patient data lawfully, the patient has to have a fair expectation or a reasonable understanding of what's going to happen to that data. So you're always going to have an element of communicating with patients about what you are doing and why. Now, rather than seeing that as something separate, it's just something we do for information governance, that's part of your approach to explaining to them how they access services, how people will be supporting them, and how they will kind of benefit, those kind of elements. The next element for kind of thinking and challenges comes from the kind of organisational relationships. And this is the one where clarity is really important, but it's actually often very hard to achieve early on in a project, because you've got to understand who is doing what. Now, in legal terms, that is, who are the data controllers? So effectively, who is telling you what to do? And who are the data processors? Who are the people that are being told what to do and when to do it? And then to have the appropriate controls and contracts in place. And that can be quite difficult, because when you're sitting down and starting the kind of working relationship, you don't quite know where you're going to end up. So you may have one vision in mind. It's going to be a hub. This is how we're going to work together. These are all the elements that are going to be involved. But actually further on, you're thinking about, well, no, it's actually this GP is going to do extended hours and they're going to provide additional service, and we'll move this service into this location. So in anything that you're doing, the first objective is to clarify who's involved, how will the data flow, how do you want it to flow, and how might that change. So you've got to build in a concept of innovation. So that's looking at when you're putting contracts together, when you're putting things like data sharing agreements, having the concept of this will change over time. The third element to all of that is kind of a governance body and a group of decision makers that are supporting your new ways of working, your information sharing going forward. So these are people that are going to be able to sit in a room and make decisions about what the appropriate way forward is. So these would be about what services are commissioned, what kind of budget you should spend on patient communication, how you garner feedback, and how you build that into the next kind of thing that you're doing. So those are the kind of the three areas of challenges as I would see it. In terms of the lessons learned, there are likely to be people either in your region or your locality or next door localities that are trying to do something very similar to yourselves. They're trying to innovate, they're trying to bring in new technology, they're trying to look at new ways of working, and that what the attempt is to not cut across each other and actually support each other. One of the most interesting things I've kind of learned is that I saw two people having a stand-up row about pseudonymization. They wanted to flow data that wasn't identifiable in order so they could figure out what the capacity was, whether appointments were being used. The problem is this argument had apparently been going on for months. They hadn't checked that they both meant the same thing by pseudonymization. One of them meant something very different to the other. So when you're using these terms that have often been, are quite new and might not be known in context, it's sometimes worthwhile just going back and concept checking that you're talking about the same thing. So language, clarity, those are the kind of some of the key lessons that I've seen. The other element was the art of the possible. Now, a lot of projects kind of have this concept of this is the way we're going to work. This is how this is going to look like. It's going to be brand new and shiny. It's going to be fabulous. It's going to be everything's going to do it the way that we want. And they get to the first fence and it doesn't exactly work the way that they want it to, so they stop. And they keep trying and aiming for this kind of perfect solution. Those that have made progress over the last 3 years that I've seen have concentrated on the art of the possible and on maintaining momentum. If there is, if you can't bring people with you, if there are people that are not ready at this stage to kind of join into a record sharing initiative or willing to provide X amount of data, you need to continue moving. It may need to make its case by bringing other people with you before you go back and explain to them and show them the benefits. The other key elements is kind of thinking through the feedback loops. A lot of the time we figure out, okay, we need to get the data from this clinical intervention to the 111, to this hospital and to these people, but we never think about the data going back. So we never think about the fact that, okay, there's a query about that information or we're not sure that information is accurate. So we never think about the reversing the flow, and we don't spend enough time at the start thinking about how are we going to prove that this has had value? How are we going to show that we've made a difference? There's a qualitative element to that, and there's a quantitative. Getting your patients involved in one sense about asking questions of how they found the changes in service, but also talking to them about the use of their data to help you understand how the service is actually working.
CQC is relatively, it's a relatively new thing that we've achieved around primary care, but that is our role, to register those that provide services in healthcare, to monitor, then inspect and rate, to, if we find poor care, and quite unusually in primary care, we do have enforcement powers, and we also provide an independent voice to speak about what we find in the system at arm's length from the rest of the system, so you all know what we do. The scope is massive in terms of the remit, and in terms of primary medical services, we've currently got 9,000 registered providers, and of course that's growing, it sort of may grow and then decline again as the configurations of primary care flex in England. Overall, we use ratings, so we will go in, we'll look at data, we'll inspect, we will publish a rating, and we're focused on improvement, and hopefully we can demonstrate the improvement that some of this process has led to, although it was not without controversy. It's the first time that we've done this in this country, but we're just finishing a programme of primary care inspection, and we've got some really interesting data from that. But look at 87% of GP practices that we have inspected, and we've inspected now all of them that were registered in October 2014. And we're providing a good or outstanding standard of care. We rate by key question areas, so whether a service is safe, effective, caring, responsive, or and well led. The one that performs least well, I suppose, but still performs well, is safe domain, because there's a huge amount of things to actually pay attention to and get right in that domain. The one that we, not surprisingly, find most often people score really well at, because it's why we all come to work, is the caring side of things, and we find that across the sectors. We published in October a quite sort of detailed observation of our findings around the whole of the system, and it's clear from this the picture that we've been discussing and you've been discussing in the room today, and the need and the drivers for transformation and innovation. So please have a look at that, and you'll find it on our website if you haven't already seen it. A summary of the map of the country and all the little clusters of good. The majority of GP practices provide a good quality of care to their patients, and this is the first time in the in England in this process that we've actually been able to demonstrate that and point at it and see how it varies across the country. We found that even those very small number of practices that did require improvement or were inadequate, and those that were placed into special measures, 6 months later, and having had a lot of, often had support from different parties, that we do find an improvement pattern on re-inspection. So there's something about the process there, delivering improvement. The success of the whole of our system relies on effective primary care. But of course, what we've been talking about today is how GP practices are changing, forming federations and at-scale providers, including things like multi-specialty community providers, or whatever label we put on that. Labels are less important than this is about whole system transformation. So I think our key message is we've done one consultation already to ask you what you thought should be our approach in the next phase of inspection to pick up on these emergent models. But staying with the governance theme, GP practices are generally well led, but these were the sorts of success factors that we did find in practices that are outstanding, really putting patients at the centre of thinking about how are you responsive to that patient group, what do they need, how do we actually get real embedded patient engagement, because it does really make a difference to what we do. Having really excellent development and support for staff, really investing in staff training and development, and having embedded clinical governance systems, which covers a multitude, but the idea that there's a clear line of sight between the leadership of that practice, whether it is a partnership or whatever the entity is, and what staff on the ground know is the purpose, what staff on the ground know they should be doing if they find a significant event, who they know is the responsible lead for particular areas of care, and those are the things that make a fantastic difference. And it won't surprise you to know that there's a correlation with the capability of the practice manager, and this makes a fantastic difference to the delivery of quality services in primary care. Just the success factors, if we invest in strong governance and visible leadership, in clinical leadership and managerial leadership, then that is a positive outcome factor. The reporting of safety incidents, having a systematic process for that, consistency of quality improvement, policies and processes and measurements in the provider, focusing on improving access to services. There's many fantastic examples of practices that are in some of the most high pressure areas who are still, managing to deliver using innovation and using their own creativity and thinking about what they're doing. We also have looked at a lot of providers who look outside the practice walls, work in a connected way with their local health economies, and we have a medicines team at CQC that often go along on inspections with special advisor GPs, and medicines optimization is one of the areas that that practices can really focus on and get right. So I'll hand over to Karen to talk about the next phase and what we're doing on consultation just now.
Our plan for primary medical services is that in the next coming months we will test the evolving model for the current GP approach that we've been using, and we'll implement and start using that new assessment framework from October. From October until April, we will then start to test how we may regulate the larger scale general practice, such as your federations, super practices, and then moving forward over the next few years, testing and refining our approach to the more complex types of providers where care is delivered across a hospital, adult social care, primary care type setting. So our approach is very much about being flexible and responsive to the changing health and social care environment. putting much more emphasis on our inspectors having a closer relationship with providers, and providers giving us more up-to-date on an ongoing basis information about how the care is changing, and how also the provider as a service is changing, because we know it's not going to be a steady state within these evolving care models. Much more focus on, again, on the flexibility on the range of regulatory approaches that we could take. So for those practices rated inadequate or requires improvement, still putting much more focus on the comprehensive inspection, and depending on the rating, it may be, you know, the 6 months to 12 months. For those practices that have been rated good and outstanding, looking to extend the length of time for up to 5 years for inspection. But what will still happen is we will still do that constant ongoing monitoring, but every year every provider will have what we call a regulatory review, and that regulatory review will include information from all range of partners, the provider himself telling us about the quality of care using our 5 key questions. And that regulatory review will then look at, has something changed in the rating? Do we think the rating has it gone from good to outstanding? Or do we think the rating has maybe declined? And at that point, the inspectors can then take a range of regulatory action. It might be that based on the information, the rating confirming as it is, and then that would be updated to the provider in a letter and updated on our website. Or it may be that some form of inspection is required, but it might be that the inspection maybe focuses on a particular key question, or maybe focuses on a particular area, such as a population group or a pathway. And I think, as before mentioned about, you know, holding those to account, so we've got quite a lot of a longer term approach to, again, evolving our registration, which we'll signal about more of that in our consultation. So our consultation we're looking to publish round about the middle of May, so really welcome your feedback, and please do look out for that.
Today I just thought I'd run you through some work that we did over the summer that has led to where we're at presently, and just to tie some of the aspects in that we've learned about how governance can help on the indemnity front, particularly as we're moving towards these much more complex models where there are more patient handoffs, etc., and how we can try and reduce risk. It was all based on the GP Forward View announcement that GPs should be no more exposed to the costs of indemnity than secondary care doctors. The outcome of the reviews at that time, and this was back in July last year, we didn't think that we should be intervening in the market, that the present situation in terms of individual GP having their individual policy, that works quite well when you have an individual doing that. But when you're moving to at scale, CNST is a very good model when you're looking at an overall, but it doesn't necessarily influence the drivers of inflation. So if we look at the drivers, I think this is where the governance side starts to sort of come in. We know that GPs are seeing more and more patients, and as you start to work at scale, you no longer perhaps see, you know, your 5,000 patient list. You might be seeing anybody across a 40,000 patient list, and the removal of that sort of GP to patient connection can sometimes mean that more people will be inclined to take out a clinical negligence case rather than perhaps discussing it with a GP. We also know that society is more litigious. That's very, very difficult. And there is no evidence that general practice is less safe in standards. In fact, it's more and more safe, but it's often records don't match the level of safety and what people are actually being provided with. There's some other interesting facts in there about the fact that, you know, most GPs will not have a claim, but, you know, we did a survey of 4,500 GP responses in 2 weeks, and of that group there were 85% with no claims in 5 years. So, you know, general practice is relatively safe. However, it is becoming more and more common, and the statistics suggest at the moment that on average a GP might have 2 claims across on an average career that come through. So it really is something that can impact everyone. These are the areas that we've identified from a governance perspective, feel like we could work quite a lot on. So good record keeping, as I referred to, I mean, it is so crucial. You know, and I know that you probably hear that from every angle, and I know that there are a lot of data work streams that NHS England is taking forward at the moment, but the better your records are, the easier it is to rebut claims or to prove that whilst harm might have happened, that it isn't attributable to negligence. And that, of course, has an impact on whether you are able to secure a premium with a medical defence organisation and what that premium might be. Appropriate supervision, this is going to become so much more of an issue as we move to more different types of roles coming into general practice. So we saw a lot of work yesterday being talked about where we're moving more pharmacists into general practice. We are moving paramedics and so on. And it's about how do you ensure that people are appropriately supervised in the roles. How do you ensure that those patient handoffs that are between the roles, how do you record those? How do you make sure that patients are safe and that the ball doesn't get dropped? And you've demonstrated that the ball hasn't been dropped between that group. Maintaining personalised care, and I'm sure that probably seems like quite a big ask when every other aspect in the system is changing and you're doing more and more. But you know, that really does have such a huge impact in patient desire to either work with a GP or whether they feel that relationship is broken down. Again, team interaction and learning, so important. You know, the amount, I've been to various CQC events as well where this keeps coming up time and time again about how practices work well, and it really does impact on how many claims people seem to have coming through. And again, naturally related to that is education and continuing professional development. All of these, I think, become perhaps a different ask, perhaps even sometimes maybe a harder ask when you move to provision at scale. There are lots of people moving to federated models. There will be different types of care that will be incorporated in. So it will be a different ask perhaps in some areas. And I think that the medical defence organisations, from the various discussions we've had with them, they're really interested in how people can demonstrate that they're keeping these things in mind in their governance arrangements, and in order to try and calculate, you know, can we offer you a premium? Can we perhaps give you a policy where we wrap around to cover all of your other medical staff apart from, you know, aside from doctors? So if you can sort of concentrate on the demonstration of these things, because we all know that you do them, and it's always about how do you demonstrate that's the issue more so. And where you can demonstrate these things, I think that's where you can perhaps be in a better position to be gaining either slightly more attractive premiums if they are available, or indeed assuring an organisation that you're a good bet to take on for indemnity if you want to be at scale, which a lot of people are now trying to do.
Obviously trying to get population coverage, individuals working in not just in one practice, in multiple practices, but having a contract with one practice. And that just seems to be an absolute block that, you know, so for example, you might provide a really good paediatric phlebotomy service and actually you need one for sickness purposes or something down the road, but actually you can't go there because you haven't got indemnity. So then, in fact, the only people that suffer is the population. That is coming up quite a lot.
There are some people in the system are looking at different types of cover. So where you might have some cover, for example, that is for a federation. So it might run across different sites. Some people are looking into products that might be suitable to cover the activities that need to be done rather than the professionals that are doing it. We are consistently told by the medical defence organisations that as long as they know what you're doing, then they don't really regard it as any different, any more dangerous to be doing it across 2 or 3 sites that are in your federation. But it's them knowing about it. As it stands, they would be saying, I think, that they would want the practitioner to inform them and say, you know, hey, we're federated, or, you know, I'm going to be working across 2 places, and I'll be doing services out of this particular practice on these couple of days. I'm going to be working out this practice on these couple of days. And then that gives them the opportunity to tease out whether there are any increased risks from doing that and whether that would affect their desire to cover. And I think it's just when they don't know that that's happening, and they haven't had the opportunity to say, well, we wouldn't cover that, so don't do it. I think that's where people find themselves on a sticky wicket. But we know that when NHS England's talking a lot, there was a lot in sessions yesterday about, you know, trying to offer people portfolio careers and, you know, working across different locations. It is a growing issue. If you can just make brief notes of you know, perhaps issue discussed, conclusion drawn. I know that sounds like quite an onerous thing, but it doesn't need to be detailed, he said, she said. What we have been told quite a number of times actually from some of the defence organisations is that these discussions very often have taken place, the right decisions have been made, there just isn't the evidence to prove that happened, and therefore they have to think about, well it could be deemed as negligence because we can't prove it. So if you do get, you know, the chance to sort of even if you produce a system whereby, you know, you've red pen tick a decision that's been made, or you've got a little marker on your data system that, you know, you put a little star next to something where it's been reviewed and approved as a decision, for example. You know, there are things that if you try to look for an easy solution rather than it being notes, more onerous and so on, I think that would really help. We're trying at the moment to ensure that we've got a contact beyond the contact centres in the medical defence organisations, because the last thing anybody needs is a computer says no kind of answer, and often you need to be put through to the right sort of specialists who understand some of the complexities of some of the systems that you're involved in. I know that all of the MDOs are trying to move with the pace of change that NHS England is driving forward, and actually to understand what is out of hours care or unscheduled care now. You know, what are the bits that create risk and what are the bits that don't actually impact. So, you know, if people had full access to a care record, for example, would it matter if that was at 8 p.m. at night or whether it was 8 a.m. on a morning? Some of those questions. So I think if you're getting through to the right people who can ask you the right sorts of questions, that really helps. So when we've got those details, I can certainly try and get that out to you so that people can try and get through to the right people.